This will be a less than 10-minute video on delirium. Please feel free to pause the video at any time if you need to catch up. We will start by discussing the 4 major criteria of delirium according to the DSM-5. Then we will move on to discussing who, where, how, and why delirium occurs to make identifying and remembering it easier by making some connections between the etiology, the populations, the environment, and the criteria. There are 4 main criteria. Can you name them? Actually, there are 5, but I lumped 2 under etiology. At the top of the slide, you can read criteria D and E that were pulled verbatim from the DSM-5. Below are the main points. In summary, delirium has to have a medical cause and cannot be due to primary psychiatric diagnosis such as depression, anxiety, schizophrenia, etc. Here we have some common warning signs that are not typically associated with primary psychiatric diagnosis. This list is essentially a direct contradiction to many of the criteria of primary psychiatric diagnosis or common etiology associated with psychiatric diagnosis. In addition to ruling out psychiatric diagnosis, dementing illnesses and coma are also deal breakers. Criteria D and E are nice in that they point us in a direction that is often very productive, thinking about intoxication and multiple etiologies. Criteria B is what I have labeled course. The DSM-5 definition is again at the top of the slide. The essence of what it says is that the onset must be acute or occurring in within hours to days. The course throughout the day is fluctuating, which means that 1 hour the patient is sitting up, conversing, and eating, and then the next hour the patient is confused, disoriented, falling asleep spontaneously. If you consider Britney Spears' course over the last few years, one could call it fluctuating, but in the months range. Although it would certainly not be considered acute, maybe subacute at best. But she is a good poster child for course when we consider where she was and where she is now. Consciousness represents criteria A, which is typically the most specific indicator of delirium. Again, the DSM-5 wording is at the top. This often manifests as a patient who is difficult to rouse from sleep and falls asleep mid-sentence during the interview. This patient might also be distracted by the numerous sounds going on outside his room in the hospital and lose track of what he is saying. We typically test concentration by doing serial 7s and are spelling world backwards. In this picture, there's a sight we have all seen of a patient in the hallway falling asleep midday. This gentleman is clearly receiving excellent nursing care, as evidenced by his clean gown and orderly blanket, though. Criteria C is often the most memorable of signs of delirium, although it is also very nonspecific and can be misleading. Visual hallucinations often lead to unusual or agitated behavior in the hospital, and what ultimately leads to the psychiatric consult. Remember that different kinds of hallucinations can often give us clues as to possible etiology. Auditory hallucinations most often occur in the setting of primary psychiatric illness, whereas in delirium or withdrawal, we see visual hallucinations most commonly. Other types of hallucinations are often most commonly associated with neurologic disorders such as seizures. Disorientation is another thing that can be a little tricky due to the waxing waning course. In one visit with a patient, she might be fully oriented, then in another, have no idea where she is or why. So to review the criteria: 1. Medical cause. 2. Acute onset with waxing waning course. 3. Altered consciousness. And 4. Change in cognition. Let's move on to consider the population who most gets delirious. This list is in order of decreasing odds ratios, meaning that old age has the highest correlation with delirium. These risk factors can be lumped into categories that align with both etiology and treatments. Old age, dementia, medical illness, diminished ADLs, and hearing or visual impairments are all common factors in the aging population. As a result, much of our treatment is frequently focused around returning perceptual capacities to minimize the likelihood of perceptual disturbances, as noted in the cognition category, which can often be confused with being disoriented or experiencing hallucinations. Hearing aids, glasses, or getting people up and moving are invaluable to the treatment of delirium. Medical illness, alcohol, and abnormal sodium all point to frequent etiology that is associated with delirium. Where patients with delirium are most often encountered aligns with both the population and again signifies the most likely culprits in etiology. Multifactorial etiology goes hand in hand with ICU patients. Ventilation often is a sign of the severity of the illness or trauma. Surgery has a wide range of occurrence, not dependent on the procedure or the technical quality of the surgeon. These rates might seem quite high in relation to what you might have experienced in the hospital on both the medical and surgical rotations. This is largely in part due to what is considered hypoactive delirium and is often not detected or treated by the primary team, especially in ventilated ICU patients. The pathophysiologic mechanism of delirium has not been definitively determined. There are two main approaches. Neurotransmitters. The first involves neurotransmitters. There's some evidence from our use of anticholinergic medications that often have delirium-like signs and symptoms. You can recall the saying, blind as a bat, mad as a hatter, red as a beet, dry as a bone, bowel and bladder lose their tone, and the heart runs alone, which is a way to remember the signs of anticholinergic toxicity. Also consider dopamine, which is thought of as being excessive in psychosis and diminished in Parkinson's. You can see how changes in cognition associated with psychosis and similar symptoms that often occur with the medication treatment of Parkinson's resembles delirium. The other model focuses more on the inflammatory cascade and the deleterious effects thereof. At the center of the theory is there's inflammation in the brain. Lastly, I'd like to introduce you to a mnemonic that helps one remember possible causes of delirium. This list may seem a bit redundant of prior lists, including the risk factors and locations where delirium occur most often, but this again emphasizes the most common etiologies is just another way to consider all the aspects of delirium. A few we haven't discussed as much, deficiencies such as vitamin B deficiencies in patients who have alcohol dependence, as well as heavy metal exposure such as lead and mercury, are other less frequent causes. The most common causes being, again, the older patient in the ICU who is ventilated or hypoxic, in other words, with a likely metabolic abnormality and numerous deliriogenic medications. Feel free to pause after each question to give yourself an opportunity to answer. So to review, our 4 criteria for delirium are what? 1. Medical cause. 2. Acute onset with waxing waning course. 3. Altered consciousness. And 4. Change in cognition. What populations are at greatest risk? The elderly with impairments and medical illnesses that typically means multiple medications. What is the most common setting for delirium to occur? The ICU, more specifically the ventilated patient. What is the mnemonic for the most common causes of delirium? I watch death. Thank you for watching. Now go to the PDF handout below this video and print it out. It can be a handy review of all the things we've just discussed and also help guide you in your patient interactions.